Hello, my name is Kelly Tebow, and I'm with the New Jersey Center for Tourette Syndrome and Associated Disorders, and I will be your organizer for this evening and would like to welcome you to our webinar on attentional and neuropsychological difficulties experienced with epilepsy. Thank you all for joining us. Before I introduce the speaker for tonight, I'm going to cover some housekeeping items with you. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. You may send questions during the webinar. However, we will have Dr. Murphy answer those questions at the end of her presentation. In addition, tonight's presenter is available to take your questions on the Wednesday webinar blog, which is accessed from our homepage under the heading Programs. This blog will be monitored for the next 7 days. Feel free to look and post questions as often as you like. Answers will be archived for future reference. If you missed part of the presentation or would like to watch it again, an archived version will be posted to our website. We value your input, and in order to expand the webinar experience in the future, we need everyone to fill the survey out as you exit the webinar. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Tonight, we are welcoming Dr. Hilary Murphy. Dr. Murphy is active with NJCTS and has done numerous in-services for us, as well as two other webinars on ADHD. Dr. Murphy is a licensed clinical psychologist and formally trained in pediatric neuropsychologist with a specialization in neuropsychological assessment of neurodevelopmental and neuromedical disorders. Dr. Murphy has extensive experience evaluating children, adolescents, and young adults. Her training in school psychology provides her with expertise in collaborating and consulting with educators and other professionals. She adopts a multifaceted approach to neuropsychology assessment, which takes an individual's culture, social emotional functioning, cognitive profile, and academic performance into account to develop a holistic understanding of each patient's unique presentation. Welcome, Dr. Murphy. We look forward to your presentation this evening.
Thank you so much. I'm so excited to be here again to be able to present on this topic. One of the things that always excited me when I was studying as a student and as I entered into my field was understanding the needs of a lot of the different patients that I had the privilege of working with. And one of my greatest areas of interest was in working with individuals with epilepsy. This is a really broad topic. I really want to be able to give everyone who has joined here today a general knowledge of some of the topics that we want to talk about. And certainly we won't be able to go into as much depth as I would like for every individual kind of part of this kind of discussion, but I really want to start to at least expand the discussion of some of the cognitive issues that individuals with epilepsy can experience. Now, one of the things that I always like to start with is outlining some of the objectives that I have. Certainly, one of the biggest questions that I typically get whenever I meet with a client is, what is a neuropsychologist? What do you do? We're obviously going to talk a lot about some of the attentional difficulties that individuals with epilepsy can experience, focusing a lot on attention and executive dysfunction. I also want to tie in some of the stressors that individuals with epilepsy can experience and how these kinds of psychosocial stressors can then impact aspects of cognitive functioning. And we're going to talk a little bit about how the findings from a neuropsychological evaluation can be used to help to guide things like treatment and appropriate interventions. Now, one of the other things that I like to talk about too, because certainly I'm presenting this through the Tourette's center is is there some relationship between something like epilepsy and tic disorders such as Tourette's syndrome? Well, the answer is yes. One of the things that we know about some of the research that has been coming out recently is that there is a higher risk for individuals who have tic disorders like Tourette's to also potentially develop epilepsy and seizures. In addition, certain seizure presentations, specifically what we call myoclonic seizures, which are these kind of brief movements, they usually look like jerking movements, can often be mistaken for tics and vice versa. Sometimes these complex or subtle motor tics can be mistaken for epilepsy. And in addition, one of the things that we always want to talk about is that certainly in terms of the cognitive profiles, we know that individuals with epilepsy and tic disorders are also far more likely to experience things like attentional weaknesses and anxiety. And so, certainly, there's a lot of overlap whenever we're talking about something like a neurological or neurocognitive disorder. And so, I think it's always good to remember that while these are really distinct experiences, there can be a lot of overlap once we get to kind of the cognitive functioning piece. And we'll talk a little bit about why that is later on as we get into that area. Now, like I mentioned before, oftentimes I get the question whenever somebody comes in, one of my first things to start with is I say, have you ever heard of somebody like me? Do you know kind of what you've been referred for, what we're going to be doing today? And oftentimes I get the response of, I'm not sure. Sometimes people will say, I know I'm supposed to be answering questions. Some people say, I know we're going to be doing a series of tests. So, one of the best things to kind of understand about a neuropsychologist is that essentially it's our job to understand brain behavior relationships. What that means is that we study all areas of cognitive functioning. Cognitive function is a really broad term. It encompasses a lot of different domains. So, one of the things that we do is we want to take a presenting concern. So, if someone's coming in and saying, I'm having attentional weaknesses, I want to better understand what I can do about it. We look at their medical history. We look at reports from their parents. If they're adults, then oftentimes I'm talking to their spouses or significant others. We get teacher reports, cultural and linguistic factors. We combine that with things like behavior as well as how an individual performs on the tests that we give. And essentially, what we do is then we provide a lot of recommendations about how we can support someone to be a successful student, to be a successful adult, to achieve the goals that they've set out for themselves. Now, like I mentioned before, when we talk about cognitive functioning, that's a really broad umbrella term, and it includes things like general IQ, language skills, visual, spatial, and nonverbal abilities, aspects of fine motor functioning, attention and executive control, we're going to be talking about today. We look at aspects of memory. How does an individual learn? We can look at areas of academic functioning and tie that in together with how someone is doing socially, emotionally, in terms of their behavior regulation, and essentially then try to design a treatment plan, collaborating with schools, collaborating with parents or other providers such as speech therapists, applied behavior analysis specialists, just to make sure that they're kind of given wraparound care. We try to address all of the areas that could be impacting someone. Now, one of the first things I think is important to talk about is what is epilepsy? Oftentimes when I explore this topic with clients when they come in, we have kind of a general working knowledge, and it's usually informed by what we've seen on TV in terms of what seizures look like. Certainly, there is a really wide variety of what seizures can look like in different individuals. So, when we think about epilepsy, this is essentially a disorder that's characterized by seizures. And when I use the term seizures, it means that there is abnormal electrical activity in the brain, and because of that abnormal electrical activity, there's changes in behavior. For some people, like I mentioned before, it can look like jerking motions. People's muscles can tense up. For other people, it can actually be far more subtle than that. You can see what are called absence seizures, where essentially an individual can be looking straight forward or kind of involved in something. They may stop what they're doing, or I love this phrase because I think everybody kind of knows what I'm talking about when I use it. They look as though they're zoning out, and just for brief periods of time, and then they seem to snap back, they come back. Now, again, when we think about understanding why it's important to know how something like epilepsy can interfere with attention and why it's important to think about screening for epilepsy when we are considering if a child does have kind of inattentive issues or problems with maintaining focus, it's because we know that these kinds of absence seizures oftentimes just look like a child being distracted. That's exactly what it looks like. And because they are so brief and they can be so frequent, it's not unusual for many of these kids to initially be referred for an assessment because people worry that they may have ADHD because that's exactly what it looks like. So certainly one of the things that we know is that it's not always kind of this, what we think of as a big or what we used to call a grand mal seizure where someone kind of stiffens and shakes and all of these things. Seizures can come in a lot of different forms for a lot of different people. And one of the things that we know is that despite what they look like, there's always going to be an impact on how a person thinks and how a person behaves. And that's why working not just with a neurologist and other medical professionals, having someone like a neuropsychologist is very, very important to help you to understand a child's needs, especially as they get a bit older. Now, when we think about prevalence, again, one of the things that's important to remember is that epilepsy is quite common in terms of neurological terms. And one of the most important things that I think is very kind of confidence building for us is the fact that many individuals are able to control their seizures with medications. But the thing to remember is that when we use these anti-epileptic drugs or AEDs, that's how they're typically referred to. That's probably how I'm going to refer to them as we move through this talk. That is something that's very important for seizure control and medical functioning. But like any medication, there are often side effects that come along with it. So, like I mentioned before, we know that somebody's functioning when they have epilepsy in terms of their attention, it's going to be impacted. Well, one of the side effects of some of these medications, and there's a wide variety of them that are available, can also be that it slows people down and it can impact their attention also. So, in a lot of ways, sometimes we see this kind of two-pronged kind of issue coming in and interfering with a child's functioning overall. And what we know is that even when we achieve the seizure control, we can still see some of the cognitive difficulties that are just associated with having something like epilepsy. So it's important to remember oftentimes, and understandably so, one of the biggest focuses once a child is diagnosed with epilepsy, which typically happens after 2 or more unprovoked seizure episodes, they want to focus on medically stabilizing the child. We want to get a medication that works. We want to make sure that the seizures stop. And that is absolutely common sense. But then after that, there's a lot of other things that can happen because now you may have a child who is then coping with a chronic medical condition. And this is where some of those kind of stressors that we're going to talk about a little bit later on really also start to play a part in a child's functioning overall. Now, when we think about how the brain works, one of my favorite kind of ways to explain it is to think about it as an orchestra. I'm going to talk to you about specific areas of the brain that can be impacted when we have attentional weaknesses, when we have certain kinds of seizures. But the thing to remember is that whenever we are performing complex actions, focusing on something, taking notes in class, trying to write a paper, trying to follow through on a conversation, we are using multiple areas of our brain all at once. It's why a lot of times when people will talk about the fact that we only use 10% of our brains, I assure you that is not true. We are using a lot more of our brains, to be able to function in daily life. One of the things to remember is that when there's one area of the brain that's impacted, everything else is also going to be thrown a bit off kilter. That's quite important when we think of something like epilepsy, because there's two different kinds generally. There's focal epilepsy, meaning that just one part of the brain is where the seizures are coming from. And there's another kind called generalized, meaning that it starts in one place, but then what happens is that other areas of the brain are involved. So when we think about generalized, it means it's not just one area, lots of other areas are starting to get involved too. Whenever there's any injury to the brain, everything is thrown off in the same way that if you take out one section of the orchestra will play the song, but it's not going to sound right. There's going to be something wrong or missing. And that's the same thing that happens for anyone who has any kind of neurological or neuropsychological issue. They're going to be able to perform tasks, but not as efficiently, not as effectively, or potentially not as easily as individuals who don't have that kind of disorder. Now, when we think about some of the co-occurring conditions, meaning that this is something that we often see in someone who also has epilepsy, there's several different cognitive issues that are very frequently implicated or that we frequently see. Obviously, ADHD and executive dysfunction is one of them. We're going to be talking about that in a moment, but also things like mood issues. Autism is quite common, learning disabilities, and intellectual disabilities. So there's all of these really complex behaviors that can be impacted when someone has this ongoing medical condition. Now, let's talk a little bit about what we mean when we say something like ADHD or attention and executive functioning. Most of our kind of attentional functions and what we think of as executive control, and I'll define both of those in a minute, they live in the area of the brain called the prefrontal cortex or the frontal lobe. That's that red area in the diagram there. It's the foremost part of the brain. And what a lot of people think is they assume that because something like attention and executive functioning isn't fully developed until we're close to kind of young adulthood, anywhere from our teen years to kind of 20s or so, kind of college age. It means that we're kind of going along, this part of our brain almost isn't online, and then we wake up on our 18th birthday and boom, there it is. Now, one of the reasons that this part of the brain is so important, particularly for adolescence and young adulthood, is that one of its greatest kind of demands, one of the biggest skills it has, is self-regulation. So we're able to stop ourselves from acting on impulse. We're able to follow through on goals. We're able to kind of resist short-term distractions, to follow through on something that we know we have to do. And one of the things that we know is that it's not that it just turns on our 18th birthday. It is slowly developing over time. What's quite interesting is that we actually start to see some of the building blocks for attention and executive functioning starting as early as infancy. If you've ever seen a baby laying in a crib looking up at something like a mobile or a toy, and they start kicking their legs and focusing their eyes, well, that is the building block that will eventually become their attention span. And what's also very interesting is that when we think about executive functioning skills, we actually see that there are kind of these windows of like big periods of growth. Think of them as like growth spurts for your brain that happen. The first one is actually in preschool. And if you think about it, a child being able to follow along with classroom demands, kind of stop themselves from butting into conversations, being able to wait their turn as they play games. All of these skills are the ones that are starting to come online, being able to express themselves when they're upset or frustrated. The next big kind of jump in terms of development actually happens towards the end of elementary school and then middle school. And then the brain is kind of fully functioning once we get kind of into late adolescence and early adulthood. Now, you might say to me, well, why is that so important for this kind of a presentation? Well, it's important because if a child has a disorder, something like epilepsy, that presents early in their childhood, and certainly there are certain epilepsy syndromes that can present as early as infancy and follow someone, or occur kind of in the middle of early childhood or elementary school, what we know then is that it's going to disrupt the brain's ability to kind of build this structure here in particular. So again, when we think about the orchestra kind of analogy, it's interfering with that one section of being able to kind of fully participate with the rest of the orchestra. Now, oftentimes when we think about attention, we have a really narrow view about what that means. Attention is really fascinating. There's a lot of different pieces to it. Now, when we think about kind of attention as a neuropsychologist, I think about the fact that we're not just paying attention, as I like to say, in a vacuum, meaning that as you're listening to me right now, I'm going to bet that you're ignoring some of the things that are going on in your background. Perhaps the rest of your family moving around in your house, things going on outside your window, the desire for you to maybe sit and scroll through Instagram as you listen to this webinar. Now, one of the biggest features of attention, and one of the things that we know is kind of the distinguishing factor between someone who has really good attention and someone who perhaps is struggling a little bit more, is the fact that someone isn't just able to focus, they can resist any distractions. They can ignore other things in their environment that aren't as important. So if we take the example of a classroom, a child who has a very good kind of grasp on attention can focus on the teacher talking and doesn't notice as much that someone behind them is clicking their pen or something's going on outside in the hallway. They can focus on that because they know that it's what's important. For a child who struggles with that, essentially their brain can't really focus on what's important. It can't distinguish what it is that they're supposed to be paying attention to. So if everything is equally important, then we're listening to the person with the pen, and then we're listening to the teacher, and then there's something that's going on outside. Oh, and then I think to myself, I don't remember if I packed my lunch today. That's going to be something really important. And the next thing, oh, I wonder what I'm going to have for dinner when I get home tonight. You can see how all of these distractions, all of these thoughts, if they're given the same importance, they're going to get into somebody's way. Now, one of the other things that we know is that it's not just paying attention, it's also being able to kind of divide our attention. Now, the best example I have for something like this that's a very practical thing is being able to take notes when we're in class. So one of the things that I always like to clarify is that people think that something like multitasking exists. People can't really multitask. When we think of something like multitasking, you do one of two things. Either A, you do two things, kind of switch from one to another. So in the example of taking notes, you look up at the teacher briefly. In your mind, you kind of paraphrase what she's saying and you start to write it down so that you have brief reminders of what you have to say. Or the other part that people often think is multitasking is you do something that's so kind of overlearned for you, you don't have to think about it. Think about like walking and chewing gum. You don't have to pay as much attention to either of those tasks. They're kind of automatic for you. But if I said to you, I want you to walk and also solve a really challenging calculus problem, well, you might not be able to kind of keep walking and do that at the same time. Now, the reason I bring that up is, again, oftentimes when I work with especially kind of adolescents and teenagers with attentional issues, that they'll say to me, well, I like to do multiple things at once. I like to have music in the background or a TV playing, or I like to have my phone here because I'll go on my phone and then I go back to my work. And usually what I'll say is that I feel like those are all distractions. Those are things that are kind of time sucks. And again, we'll talk a little bit more about that when we discuss briefly some of the potential treatments that we can use or interventions that can be helpful. Now, when I refer to something like executive functioning, one of the things that's really important here that I always have to outline is that there is no one clear agreed upon definition for what we think executive functioning is. Now, the way that I have always thought about it, the way that oftentimes people who work in kind of development think about it, is this really broad term. It's an umbrella term that has all of these different skills that are required for goal-directed behavior. Everything we need to set a realistic goal and follow through on the steps that we need to do to achieve that goal. Now, one of the things that is also really important to point out here is that as a child gets older, the importance of these skills increases substantially as we age. The reason for that is that obviously, as children get older, we expect them to take on a lot more responsibility for regulating themselves, for managing their workload academically, and for also navigating aspects of their social functioning. So one of the things that's also important to kind of tie in terms of executive functioning is that it's not just goal-directed activity, it's also our ability to function independently. So when I talk about executive functioning, it includes things like behavior and emotional regulation. It includes our ability to inhibit impulses. It includes our working memory, which oftentimes is tied to our attention span, our ability to manage time, start tasks, how flexible we can be kind of mentally, and our ability to plan. So whenever I'm working with somebody who struggles with aspects of executive functioning, it's not surprising for me to see it kind of bleeding into or getting in their way, particularly academically. Now, again, I work primarily with elementary, middle school, and high school aged individuals. So really one of the biggest things that I think about whenever I'm talking about something like executive control is how it then applies to academics. And one of the things that we know from research is that the importance of executive functioning has actually been found to have this really unique relationship to academic achievement, even above and beyond some of the features of ADHD or attention deficit hyperactivity disorder. Now, the reason that these two skills go together, attention regulation and executive functioning, is partially because they live in similar parts of the brain. They both are really involved in this prefrontal or cortex or frontal lobe. But also, these again are these kind of higher level skills that are developed over time. Now, whenever I think about academic functioning, again, there's two aspects of this. A, executive functioning skills are what allows a child to plan long-term assignments like a book report, to break things down, to know how long it will take them realistically to complete things, to be able to get started, to avoid procrastination, and to actually monitor the quality of their work and their behavior so that they meet the goal that they set for themselves. But also, it's important to highlight the fact that as academics become more challenging, writing, reading, and mathematics all start to increasingly draw on executive functioning skills, even above and beyond just managing demands and deadlines. It's thinking through things. One of the things that I always kind of outline to parents is the example of writing. Written expression is probably one of the most, if not the most, executively demanding skills that we have. Whether we realize it or not, in order to be good writers, we have to be able to brainstorm topics. We have to be able to plan out how long it will take to produce written work. We have to break the task down into separate kind of activities. So selecting a topic, doing research, highlighting areas to discuss, then producing a draft, editing that draft, editing again. And also, we know that in terms of being able to regulate ourselves, this is a task that is long, is tedious. One of the things that I always go back to is good writers write once, great writers write many times. And for a child who struggles to regulate themselves and perhaps get started on things and also regulate their frustration, this is going to be torturous. And oftentimes I see these two things going hand in hand. Other examples are things like reading comprehension, where we have to remember what we know from the previous chapter. We have to make these ongoing predictions about what we're reading as we read through the text. We have to stay focused. Or in mathematics, where we have to do these multi-step tasks and equations. And whenever we have a multi-step process, we know that we are more likely to make mistakes because of all of these different steps and all of the cognitive skills we need to be able to attend to something like this. So it's not surprising that even in children who are very, very capable, either intellectually or academically, we can see that they kind of fail to meet the mark. They don't perform up to their potential because of all of these underlying weaknesses. Now, when we think about what attention deficit hyperactivity disorder looks like in individuals with epilepsy, it's important to get a little bit of history. Years ago, because it was always acknowledged that there would be attentional weaknesses in someone who has epilepsy, you actually could not diagnose ADHD in a child who was already provided with the diagnosis of epilepsy. Now, over time and with a lot more research, what we've understood is that for some individuals, the attentional weaknesses that they demonstrate go so far above and beyond what we would think of just for epilepsy alone that they warrant two diagnoses. So oftentimes when we're working with individuals, they can have kind of this discussion of, is this enough of a difficulty? Does it have enough of an impairment on this person's life to warrant an additional diagnosis? Or is it kind of within expectations for what we might expect for someone who already has epilepsy? And there's a lot of discussions oftentimes with clinicians about what's the use of giving this additional diagnosis. Now, personally, I think for many people, it can be very validating. And oftentimes too, because many people are not aware of what epilepsy can look like in terms of how we function and how we, are able to perform in school or perform in terms of our jobs, I think having that additional label is really useful because it gives us a quick and dirty understanding of, oh, I understand that if you have ADHD, you're going to be distractible. You might make mistakes. You're going to have all of these things. Now, we know that, like I mentioned before, it is highly, highly common for someone who has epilepsy to also be at a much higher risk of developing ADHD. And we also don't see any significant differences in terms of boys and girls on whether or not they have ADHD and epilepsy. Now, like I mentioned before, we always have to consider, could this also be a side effect of the medication that a child is on? So there's many different levels that we have to analyze in order to determine if this is an appropriate diagnosis. I always like to highlight too that whenever we as neuropsychologists are called on to make a diagnosis of ADHD, I oftentimes will get a question from parents of, you know, I feel like every child I meet has ADHD. I feel like a lot of people have this. Is this a real diagnosis? And what I usually like to explain is that for many people, we all experience times we're not as focused as we would like. We're not as organized as we would like. We, put things off. But many times these little difficulties, these idiosyncrasies, don't have a significant impairment on our ability to be successful students or successful adults. But for other individuals, it does. So whenever we're called on to make this diagnosis, that is a huge part of the equation. I've seen many people that come in for 1 or 2 days of testing with me, and they don't do as well on some of the attentional measures as perhaps I would expect. But when I talk to them, when I review all of that information that I outlined before, their medical history, their educational history, what their teachers say, what their parents say, what they say, I'll find out the fact that really there's no evidence that it's getting in their way. Could be a little bit of a weakness, but it's not something that's functionally impairing. And that's very, very important for us because sometimes I have people who come in and they assume that, well, the minute that I walk into the office, you're just going to think that I have ADHD. And really, I argue no. Oftentimes, I kind of have a clean slate. I'm not tied to any one diagnosis. I'm going to give you kind of what the data supports and what is going to be most helpful for you as you move through life to understand how you function and so that other people also know what you need to be successful. Now, when we think about what the attentional profiles in individuals with epilepsy look like, they are a little bit different from just people who have ADHD or attention deficit hyperactivity disorder alone. Now, when we think about ADHD, a lot of times there's questions about, well, how does ADD fit into this? How does just, what do these terms mean? What we used to call ADD or attention deficit disorder is now under the umbrella of this larger diagnosis of ADHD or attention deficit hyperactivity disorder. I personally do like to think of it almost like a spectrum. At one end, we have people who are very, very distractible. They're people who have a lot of those executive functioning issues. Oftentimes, they're described to me as people who move a little bit slower than their peers. They're daydreamy. They're lost in their own thoughts. They're easily internally distracted. At the other end of the spectrum, we have kids who are jumping out of their seat. They're always calling out. They really struggle to regulate their frustration. They're loud, they're active, they're, kind of the boisterous part of the room. They're the kind of stereotypical ADHD presentation. And then we have the middle where it's a mix of the two, of kind of those two extremes. What we used to think of as ADD is more of this inattentive presentation, the first one I talked about. We also have this primarily hyperactive or impulsive presentation. And then we have the far more common one, which is the combined. When we think about ADHD alone, that kind of middle diagnosis is the one that's most commonly provided because it essentially says that we have evidence of distractibility, impulsive behavior, and restlessness. Now, when we think about what this looks like in individuals with epilepsy, it's a bit different because they are far more likely to just look inattentive. They are someone who really struggles to regulate their focus for long periods of time. They can struggle on kind of persistence on tasks. They're more likely to get lost in their own thoughts. And again, if we think about some of the seizure presentations that I talked about before, that's not surprising because there are some seizures that look like attentional issues. And also we know that this is something that is kind of unique unique to individuals with epilepsy. Now, the other thing that's very important is that for many individuals, these attentional weaknesses are often seen or they're reported before seizures emerge. So there is some suggestion that there's some change in how someone is functioning before seizures are even present in that person's life. There's something that's different about how their brain is working. Now, I talked about the fact that there are a lot of psychosocial stressors that can come along with being someone or being an individual who has a chronic medical condition. For a lot of kids, there can be this sense of guilt. There can be this idea that, people don't have as high of expectations of me, or there can be a fear that they may have a seizure in public. And again, like I mentioned, seizures can look very different for a lot of people. For some people, it's very subtle, and for others, it's very, very obvious. And for a lot of kids, especially adolescents, it can be quite embarrassing and frightening.
One of the things that we know is that unfortunately for a lot of kids, what can happen is that they can be reluctant over time to remain consistent with their medication because there can be effects of their medication on their ability to consistently pay attention. They can feel slow or sluggish or lethargic. For some people, it can cause some kind of irritability or mood changes. And so again, there's all of these other things that can come into play. And also the fact that there can be a family burden for a lot of individuals. Certainly having a child with a chronic medical condition can be a stressor, both emotionally, financially, and oftentimes kids do sort of take on this role in their families of feeling like they're the one that's sick, they're the one that is the quote unquote problem. And again, when we think about how well parents and family members and other caregivers react to a child with epilepsy, that can be quite important. Now, the reason that I talk about aspects of stressors in the context of this kind of talk is the fact that one of the things that we know is that the presence of any level of distress, whether it's anxiety, depression, or just general tension, it's going to have a negative impact on our attentional resources. The best way to think about this is the fact that for us, our brain has a limited amount of attention it can give at any given time. Think of it like a bank account. You have so many attention dollars at, any point in your day. If all of your attention dollars are spent on thinking about how upset you are, how frustrated you are, something that went wrong in terms of, your relationship with somebody else, or if you've ever had a day where you're just really preoccupied with something that you need to take care of, or a fight that you had with a loved one, you can probably relate to the fact that when you were at work or wherever you were in that day, you weren't your best self. You weren't fully present because you were so consumed with this. Your attentional dollars are being spent on this stressful event. Well, if you combine that with the fact that somebody with epilepsy and ADHD, or just either one of those issues alone, already is kind of at a deficit in terms of their attentional dollars, you can see why the addition of any stressor is going to make it even harder for them to consistently perform up to their potential. It's also important because we know that there is a really high prevalence rate of mood disorders within the epilepsy population, and that for some individuals, their seizure presentation can include mood symptoms. There are some people where the way that their seizure comes on, so if we talk about, the ictal period, ictal meaning seizure, they can get frustrated, angry, aggressive, or very, very depressed. We call that kind of ictal anger or ictal depression, or there's also ictal anxiety. So couple that with the fact that then you can have just this ongoing stressor of, I don't want to have a seizure and somebody else sees it. Am I going to be okay? Do I have to take medicine for the rest of my life? Why did this happen to me? Are mom and dad okay? They're really worried about me. I want to be more independent. Can I drive? Can I go out on my own? All of these really basic things that we think about in terms of independence, that may be challenging for a child who has this chronic medical condition. Now, when we think about the fact that there are certain risk factors for having a mood disorder, again, it's all of these complicating issues. We know that for some people, it's having a brain injury. For a lot of children, when we kind of think about how kind of seizures come on or why they experience epilepsy, one of the causes can be a head injury. It can be acquired epilepsy, as opposed to someone who has more of a congenital disorder where it was something that was present at birth, or for some people, we're not sure. We're not sure why they have them. We know that there is this genetic link, but it's not, direct one-to-one. So it's a really complicated disorder that can come about in a lot of different ways. There can depend on the severity of the syndrome. Certainly, we can have syndromes that really don't have a significant or severe impact on daily life, all the way up to someone who is very disabled because of this condition, as well as the presence of these stressors, the family dynamics, as well as what kind of medications that they're on. So this sort of brings me to one of the last pieces before we take a little bit of time to answer any questions that may come up. And it's the question, well, how do we help then? We know that these children are at risk for having a lot of these issues. So what can we do in terms of being caregivers, in terms of being teachers or school personnel, in terms of being mental health professionals or other related therapists, occupational, speech, or kind of physical therapists? The answer is kind of multifaceted. As parents and family members, one of the most important things is to be educated, to be aware of what this is, to be in open communication with your child's care team as well as their school and with your child. It's important that we involve children in aspects of their care in a developmentally appropriate way. One of the things to remember is that oftentimes children who have chronic medical conditions, they feel like they don't have a lot of agency. They feel that they don't have a lot of control over what happens to them. And that is a really realistic reaction, because in all honesty, they don't. If they have to be on medication, that's oftentimes a decision that's made without them. If they have to see certain professionals to make sure that they're okay, whether it's a therapist or a school kind of a specialized teacher or a certain kind of doctor, all of these decisions are made without them. So whenever we involve them in a way of talking about why we have to do some of these things, how we want to handle some of these kind of concerns, I think that can be very, very empowering for children. And as they get older, making sure that the rest of their treatment team, whether it's clinical, whether it's medical, whether it's school-based, that they slowly involve the child in this process as well. As teachers, oftentimes it's understanding that children who have something like epilepsy and ADHD, they are going to require specialized care, and that really one size does not fit all. Certainly, we know that there can be a lot of cognitive issues in individuals with epilepsy, but one of the risk factors for having this negative kind of outcome is if we have lowered expectations for these child. Many individuals who have epilepsy and ADHD are functioning within normal limits, if not above what we would expect cognitively. Their reasoning skills are well developed. They are capable of success. But whenever we have the presence of this kind of medical condition, we oftentimes want to, understandably enough, kind of take some demands off. And that's not always something that's helpful. We want children to feel like we're meeting them where they are. We understand that certain things can be challenging, but also that we have appropriate or high expectations of them so that they do learn how to strive in terms of the finding their best, whatever that may be. In addition, making sure that you have open and ongoing communication with the family. Like I mentioned, oftentimes when we see some of these behaviors, especially in ADHD, it's not unusual for these kids to be mislabeled as the kids who are the class clown. They're always disruptive. They're trying to get out of it. Now, certainly one of the things that we know about attention is that it is highly tied to motivation. If you are not interested in a task, it is going to be far more challenging for you to consistently pay attention to that and follow through. The example I like to give is the fact that if you put me in a classroom talking about psychology or epilepsy or one of these things that I'm very, very interested in, conspiracy theories, I'm going to be able to pay attention probably for hours at a time. But if you put me in a calculus class, which is something that I am not interested in and also not good at, it's going to be much harder for me, despite the fact that I can regulate myself a little bit better. That's also a misconception about ADHD. Parents will sometimes say to me, well, they can have attentional issues because if I give them Legos or a video game or something that they love to do, they can do that for hours. But in reality, one of the ways that I think about ADHD, it really is a primary deficit in our ability to stick with things that perhaps are not as intrinsically interesting or kind of engaging for us. One of the biggest skills as adults that we develop is the ability to understand that we have to kind of do the short-term work to have the long-term gain. You know, being able to push through a class that we don't really like, but knowing that that's going to help us, you know, when we get to college or to kind of get the grade that we need, or using it as a stepping stone for something else. You know, making sure that we don't just excel in things that we really, you know, are more interested in, that we are also trying our best in everything else that we do. In terms of being involved in aspects of mental health, one of the things that I think is very important, and I think it extends not just to mental health, but to any time that we are involved in treatment with a child. One of the things that I think can be quite challenging is the idea that we consider this, how do I like to say this toxic positivity. You know, one of the best examples that I have of this was when I was training as a postdoc. I was actually in a rehab hospital, meaning that I was working with children who were kind of recovering from things like traumatic brain injuries or brain surgery or any of these things, where oftentimes they were given this really intensive care in terms of speech therapy, psychological, cognitive therapy, physical and occupational therapy in order to help them regain skills. And when I was participating in one of these therapy sessions, whether speech or OT, with one of the clients that I worked with, I made the mistake of saying, you know, it's all going to be okay, or one of those like just general platitudes. And the child turned to me and said, no, it's not. I had an injury and now I have to relearn how to walk and to do things that I never thought about before. And so one of the things that we have to remember is that in our effort to be positive and not feel uncomfortable when working with these really serious concerns, these really kind of chronic conditions, is that yes, we want to say everything's going to be okay, but sometimes it's okay to not be okay. And it's okay to give children that space to say, this is hard for me. I don't like having to take medicine. Or in the case of certain epilepsy syndromes, kids may be on this extremely strict diet, where then we have to explain to the family why they can't have things like a birthday cake or cupcakes even just one time, because unfortunately that raises the risk of something like a breakthrough seizure. So if you ever read about a ketogenic diet for certain epilepsy syndromes, it's something that is really important for medical functioning, but has this secondary effect on our social skills, especially for young kids. How can you go to a birthday party and not be able to have some of the treats and goodies that are there? And how do we explain that to a child who's still very young, you know? And again, it's sort of a simplistic example, but I think it's important to remember that we can't just focus on one area. So whenever we have a medical concern, it can't just be about how our body is functioning. Our body is connected to our brain. Our brain controls how we think, how we feel, and how we act. All of these things are interconnected. We can't just focus on one piece with the expense of anything else. So I hope that these are kind of helpful guidelines, a helpful discussion of this very interesting topic. In terms of treatments, you know, they can range quite wild, or I should say vary quite a bit when we think about some of the things that we recommend for children, because epilepsy can take so many forms, and because ADHD and these attentional deficits can come in many different kind of shapes, sizes, and flavors. We know that oftentimes we can range from having something like a Section 504 plan, where a child is accommodated to function in a mainstream or general education classroom, to having a really strict and robust IEP or individualized education program, where essentially there's a binding legal document that outlines not just how a child can be accommodated in a school, but it changes how they're taught. If they're given, you know, pull-out services or speech therapy or occupational therapy or placement in a self-contained classroom or a specific kind of classroom that supports language development or supports kind of adaptive skills. There's a lot of different things that we can recommend academically. There's exploring the idea of outside therapies, like I've mentioned before, of OT, speech therapy, physical therapy, working with a behavioral therapist to manage aspects of our emotional functioning. And all of these things can really be discussed, working with the school, working with an outside clinician like a neuropsychologist. I think that that can be a discussion in and of itself. So I know that we're getting down to about 10 minutes left in our time together today. So I'd like to take a moment and perhaps explore some of the questions that have come up so that I make sure that we have time to answer some of these. And then obviously also I'll be able to address some of them in the blog. And before we get to that final part, I really want you guys to consider checking out some of the additional resources that are provided through the Tourette's kind of association, because I think being able to access some of these webinars, being able to hear some of these speakers talk about areas of expertise can really open up a lot of different avenues. I know, like I mentioned before, oftentimes people don't know that somebody like me exists until they're referred to see me. There's a lot of different professions and a lot of different supports and services and so many different topics related to not just Tourette's, but other aspects of cognitive and behavioral functioning that can be so helpful for families, for children themselves to understand what's going on. So I really encourage you to check that out. So with that being said, let's open it up to some questions and kind of go from there.
Okay. Boy, you gave us a lot of information. So I'll start with our first question that came in. Can AEDs provoke TS? And I believe that's anti-epileptic drugs.
That is a very, very, very good question. Now, I'm going to say that I can give a little bit of an answer on this, but it's something, because I do not prescribe medication, would be an excellent question for a treating physician or medical doctor, so someone like a neurologist, psychiatrist. I am not aware of side effects that can provoke something like TS. However, I also recognize that AED medications, there are many different types out there, and that side effects sometimes can be rare. So I would redirect that to be something perhaps addressed to a particular neurologist, someone who has expertise in managing and prescribing medications, because they would be someone that is the most kind of knowledgeable about a subject like that.
Okay, fair enough. Fair enough. As you were talking about school-related stuff, somebody commented that there an added diagnosis other than epilepsy is necessary because educators don't truly understand that there can be modifications needed for epilepsy.
I would absolutely agree with that. I think being able to provide the most comprehensive picture is the way that I have always approached evaluations. Some people really like to be, kind of succinct and give, one or two diagnoses. And it's not to say that that's wrong in any way, shape, or form. But as someone who was originally trained as a school psychologist, I believe that providing as many appropriate diagnoses and the most complete picture of where a person is, not just medically and physically, but cognitively and emotionally, is very, very important. So I would absolutely agree with that. Oftentimes when I'm working with families, one of the things that can come up is kind of what is the most appropriate classification for my child, and certainly that varies from child to child. But a lot of times, if I have more than one presenting concerns, so something like a medical diagnosis such as epilepsy, and perhaps attentional weaknesses or ADHD, and maybe a learning disability, all of these things, do kind of co-occur together, I'll talk about the fact that classifying it appropriately as being multiply disabled or having multiple disabilities can be very, very helpful. It's a frightening term and I don't really like it, but it reflects the fact that there's more than one thing that's going on, and it allows kind of this opening up of services. So I think that that comment is very, very spot on, and I would fully agree with that. It's why also having someone who's not just a neurologist, but also a neuropsychologist can be helpful in providing those clear diagnoses.
You may or may not be able to answer this. If brain activity is considered stable with a med, is the person safe from having seizures?
Oh, that is a very complicated question. It's a very good one for a neurologist, but I will give you a very bare bones answer. Oftentimes, when we think about safe from having seizures, that can be a really challenging question, particularly in kids, because one of the things that we know is that as people get older, their brain and body changes. So their tolerance for something like a medication can also change. So for some people, we see that they can be stable or kind of what we call seizure-free on medication for a long period of time, meaning that the medication is working. Now, some people misinterpret that as meaning that, well, then I don't need the medicine anymore. And really, we know that that can be a tricky thing. Some people do over time come off of medication, but that is a really individualized thing. There is no kind of one size fits all for something like that, because it depends on what that kind of epilepsy it is, how severe it is, and how kind of a person is functioning on their medication. What that really means, if you are seizure free on medication, you are not experiencing known seizures, or you're having EEGs or kind of brain electrical studies that are saying that you're not having a seizure in that time, it means that your medication is working. That's the most accurate way of thinking about it. And it's not to be scary, it's just to also take it seriously. And it's a good thing to discuss with your physician about, you know, what does this mean for me long term? Because that really varies from person to person. So I hope that's helpful.
Okay. You talked about how if there was a class on something that you like, your attention is much better than, say, if the class was about calculus. What are some tools we can give children to learn how to better focus on the classes that they consider boring?
That is a phenomenal question. One of the things that I usually like, and one of my first kind of go-to techniques for something like that, is building in a reward. So whenever I think about the fact that let's use that example of having to study for a class like calculus, which is challenging for me and also not that interesting to me. Oftentimes when I have a class like that, or when I'm working with a student that may struggle with aspects of attention and focus when something's not as interesting, I'll say, plan something that motivates you, something you want to do. Get this studying done, this test done, this assignment done first, and then reward yourself. Because then what you're doing is you're tying in something that is motivating, is exciting, to something that's not, you know, as fun or interesting. In psychology, we call it the Premack principle, or kind of grandma's rule, meaning that before you have dessert, which is motivating, you have to eat your vegetables, studying for calculus. So that's something that can be really helpful. And depending on how old the child is and how taxing the task is, we can design behavior plans so that someone can earn rewards, whether it's small things over time, or whether it's being able to engage in a preferred task like using a tablet or kind of going online or using social media. As kids get a little bit older, we can talk about earning larger rewards. You know, oftentimes I'll talk about the fact that we don't work for free. I love what I do, but I also love to have kind of the freedom and the ability to use money to spend on things that I really do enjoy, spending time with my family or going out or doing anything like that. So making sure that we tie in the fact that there is some reward overall and make it meaningful for that child, I think that's one of the first techniques that can be helpful. In addition, making sure that the child is involved as much as we can and as developmentally appropriate as we can make it in kind of developing what is important, what's getting in your way. You know, oftentimes one of the other techniques or one of the other potential services that can be very helpful for people who struggle with ADHD or executive dysfunction is working with an executive skills coach. There are actually trained professionals who develop an individualized plan for someone who struggles with things like getting things started or kind of staying consistent on a task. And one of the things that can be helpful is that you're working with someone who knows all of these techniques and they can troubleshoot with you. And oftentimes for kids, we work not just with the child, but also with the adults in their life to make sure that they are being motivated appropriately and they're being essentially, they're staying consistent with the plan that we develop. So there's a lot of different ways, but one of the best things to do is to tie it to something that is very motivating for you.
Okay. You talked about quickly about 504 plans, and then you said something about IEPs being a really legally binding document. I just want to make a comment that the 504 is a binding document as well.
Absolutely.
You know, so don't think that one is better than the other. They're different, but one the 504 is a binding document as well.
Absolutely. I'm glad you brought
Um,
that up because essentially one allows you to stay within a general education or mainstream classroom with accommodations like sitting at the front of the room or being able to access the school nurse to, you know, kind of have a safety plan or making sure that we have an FM system or some of these other things, whereas an IEP really has these changes in how we teach kids. So I'm glad that you clarified that. Thank you, Kelly. You're absolutely right.
do all seizures have warning signs?
That's a really good question. And the answer is not necessarily. So oftentimes when we think about warning signs, we think of something almost like an aura. Sometimes before somebody experiences a seizure, they'll describe things like feeling weird, feeling a little bit of deja vu, feeling what we call epigastric rising. It's a fancy way of saying kind of like a rising in their chest, or some of these other just unusual phenomena, not dissimilar to what people would describe when they have migraines. They'll have these kind of visual changes that kind of tell them, okay, a migraine is coming on. Some people can have those, but some people don't. So for example, with absence epilepsy, people oftentimes have very little, if any, idea that they're experiencing these episodes because they're so brief, they're so frequent, and they're just not aware of the fact that there's any obvious changes in their behavior. It's why oftentimes it can be overlooked for a period of time, or it can be mistaken for something else like distractibility and ADHD. So it's something that can happen in certain kind of seizure presentations, but not always. And that's, again, kind of a really good example of how epilepsy is, you know, a broad term that encompasses a lot of different things and a lot of different presentations.
So you were talking about things that can be distracting, and in there you said listening to music or music in the background, that kids like to have music in the background. Personally, I like to have music in the background sometimes. Other times I have to turn it off. You know, it's not, is there a be all and end all? Should they never have their music on, or
That's
some kind
another
of music?
phenomenal question. I would say that there's no be all end all. Oftentimes, whenever I'm talking with people who are coming in and describing a lot of these attentional difficulties, we really want to take stock of what do you think could be getting in your way. So in the example of someone saying to me, well, I like to listen to music, I'll talk about the fact, well, do you ever find yourself being distracted by it? Do you ever get up, kind of dance along with it? Do you ever find yourself listening to the music a little bit more than writing the paper that you were supposed to be working on, or getting distracted and kind of turning around and saying, oh, this song makes me think of this, or oh, I don't like this song, and then you spend 10 or 15 minutes choosing what kind of playlist you want to play. So there's a lot of questions, because you're absolutely right. There's some people who can say something like classical music can be very, very helpful to them. Or listening to songs, like there's specific playlists that they've heard over and over again that they associate with studying. So there's not necessarily this one thing, but oftentimes what I'll say to people is that you really can only fully focus on one thing at a time. So if you're focusing on the music, you're not focusing on your work. The music should be background, meaning that it's kind of already there. And because we know that in order to fully pay attention, we have to ignore as much as we can, we want to make sure that that kind of background noise isn't making it more challenging to focus. I'm glad you asked that, because certainly attention, there's no one size fits all. It really is a lot kind of more diverse than we usually give it credit for.
Maybe because mom was always playing the radio from the time she woke up. I was
It's
just used to
okay.
music.
I
I
love it.
cannot do work in front of a television.
I'm
I
the same
cannot
way.
do it.
Same way. Same way.
Um, well, that seems to be the majority of our questions for this evening, and I appreciate your time, Dr. Murphy. So I think we'll end the webinar at this point. So thank you for everyone for joining our webinar on attentional and neuropsychological difficulties experienced with epilepsy. There is an exit survey which we need everyone attending to fill out. The webinar blog is now open and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is njcts.org. Also, an archived recording of tonight's webinar will be posted to our website. Our next presentation, Collaborative Problem Solving, will be presented by Dr. Jeremy Lichtman and is scheduled for June 30th, 2022. This ends tonight's webinar. Thank you, Dr. Murphy, for your presentation, and thank you everyone for attending. Good night.
Thank you. Good night.